Yes, we can hear you.
Okay. Great. All right. Well, I'm here. Ready to go whenever.
Hi, Dr. Burns. It's Patty Garney.
All right. Hi, Patty. Thanks for joining.
I can hear.
Thanks everyone for joining. We'll give it, we got 5 minutes or so. So we'll get going at 2 or maybe a minute after 2.
Well, I almost brought Charles to you on Monday and left him on your doorstep. But yesterday and today, he's been better.
Oh, good. That's good.
He definitely has his moments.
Yeah, I'm sorry you're struggling.
Me too. So don't be surprised if you get a knock on your door someday.
Okay, I'll be ready.
Can everyone hear me? All right, it is 2 o'clock, so we are going to go on ahead and get started today. Thank you everyone for attending and joining us today. My name is Dr. Tina Lewandowski, and I'm the Director of Engagement. Today, I'm filling in for Kelly G. Loeb. Sorry, she's not here today. She's in Wichita at an Alzheimer's Association conference. I do have one quick announcement before we get started. Tomorrow is our Dementia Training Room event. We host this event once a year, and the event is designated for our busy caregivers. We have over 15 different topics presented by experts in the field, and it's a come and go event. So you can come attend a session or two, maybe leave and come back. And the event is from 9 a.m. to 3 p.m. at Trinity Temple in Grandview, Missouri. Today, we have a special presentation from Dr. Jeff Burns. Thank you so much for joining us, Dr. Burns. Dr. Burns is our co-director here at the University of Kansas Alzheimer's Disease Research Center, which is one of only 33 national designated centers in the country. Dr. Burns started the Alzheimer's Clinical Research Program in 2004. The program has grown into a vibrant research and training environment for brain health and brain aging research. And Dr. Burns has been continuously funded as a PI by the NIH since 2005 for his work on focused work on how various lifestyle factors influence brain aging and AD progression. I wanted to let everyone know that you have the option to enable closed captioning. If you would need, just select that CC button at the bottom of your screen. And friendly reminder, please keep your microphones on mute. If you have questions during the presentation, type them into the chat. And we will be sure to leave time at the end for Dr. Burns to answer any questions that you have. And we'll have the recording available as well. Dr. Burns, we appreciate you taking the time to join us today. So I will go on ahead and turn it over to you.
Great. All right. Thanks, Tina, and welcome everybody. It's an exciting time in Alzheimer's research, and I'm going to spend the next 20-ish minutes talking about kind of updating you on where we are in terms of these new drugs. They are in the news a lot, and they're going to be in the news a lot more. It's a great time to be having this discussion, and we'll probably have more as the news evolves. But so thanks everybody for being here. If you've been paying attention to the news, over the last 2 years, we've had a lot of news in the field of Alzheimer's disease. And this was actually 2 years ago today. This article came out because the FDA approved the new drug Aduhelm, first new drug in 18 years for Alzheimer's disease to be approved by the FDA. And it was approved. It kind of surprised a lot of us, but approved and led to a lot of controversy. I'm sure if you were paying attention, you would have seen other headlines like this one, where the FDA made some changes pretty quickly after kind of a backlash. And then over time, we kind of saw this drug Aduhelm, which was created by Biogen, sort of evolve to where we didn't continue to use it. Very complex situation. A lot of reasons behind the controversy that I'm not going to go into. That'd take another 20 minutes, but kind of a confusing time, I'm sure, if you're watching through the news. Then 5 months ago, January 6th this year, the FDA approved a second drug for Alzheimer's disease called Leqembi, made by Eisai, and they partner with Biogen. That was big news. First drug for Alzheimer's disease, same class of drug as Aduhelm, but with data that really more strongly supported its effectiveness. So that led to again, an accelerated approval, and I'll talk a little bit about what that means for this new drug. And then just a month ago, another drug came out with big results, not FDA approved yet, but big results. This drug's called donanemab. The results showing that drug also appears to slow cognitive change in Alzheimer's. And so it's kind of been one thing after another for about 2 years. And what I'm going to try to do is hopefully bring some clarity to what's going on and kind of where we are today. And I'll say this, Tina mentioned we're one of 33 Alzheimer's centers. We've been right in the middle of this drug development and these studies. We've been a part of the studies that have led to these approvals. And so we've been testing these drugs, actually in this type of drugs for probably, I think, about 10 years. So a lot of effort over a long period of time has gone into testing these drugs and others, of course, but these drugs, which are now really on the cusp of full approval and use in the clinic. So where are we? Well, a whole new class of drugs for Alzheimer's is here. That's a big deal. Again, it was 18 years between approvals of the prior drug memantine, and I think 2004. And then the new drug Aduhelm in 2001, actually it was probably 2003. So it was, and then 2021, the new drug Aduhelm. So this is a big deal, and it's really a sign of all the work that's been going on around the country and really around the world to fight Alzheimer's disease. And it's a first step, I believe, and I think most people in the field believe it is a step forward. How far forward, we don't know yet, but a new class of drugs is here. Now, one thing to keep in mind is the existing drugs, drugs such as donepezil or Aricept, and then memantine or Namenda, which we've been using for 20 to 30 years, 30 plus for donepezil and about 20 for memantine. Those are going to continue to be used, and these new drugs will be used right alongside them when appropriate. So, those are still here. They're still going to be used. The new drugs are in a new class that we call monoclonal antibodies. And I'm going to talk a little bit about what that means, but monoclonal antibodies that are designed to go after amyloid. And I'll talk a little bit more about what amyloid is. So the new class, though, is called monoclonal antibodies. So where are we today? So all that news, basically, we can sum it up here. You don't need to know all this. We're going to mainly talk about the middle drug, Leqembi, because it's the one that we expect full approval from the FDA soon. But there's two drugs right now, Aduhelm and Leqembi, that have had partial approval, or what we call accelerated approval. And then the third drug, donanemab, they're in the process of submitting for full approval. They didn't receive accelerated approval, but they are in the process of submitting for full approval to the FDA like any day. An FDA decision is expected within a year, so probably early next year. So we have two drugs with accelerated approval, and what accelerated approval means is the FDA has decided that based on some observations that the drug is changing amyloid in the brain, that there's a reason to suspect it may benefit patients, and therefore they want to get it on the market quicker to meet patient demand. And so they've created this sort of accelerated partial approval where the drug's approved partially, and then more data is collected as it's being used to ensure that it actually works, and the drug moves towards full approval. And so these partial approvals in the setting of Alzheimer's disease mean they're available, but they also have sort of worked out to mean that we're not using them yet. So, and that's complicated, and that's related to all the controversy from that first drug that was approved, Aduhelm. It sort of led to a Medicare decision not to pay for these drugs unless they're given in the setting of a clinical trial. And that basically restricted their use to the point where we really aren't using them in the clinic, yet we're waiting for the full approval. So partial approval or accelerated approval, where we really can't use them unless you want to pay a whole lot of money for them. And then full approval, which is sort of traditional approval. And as we'll talk about, Medicare will cover those drugs when they're fully approved. So Leqembi is basically on the cusp of approval, and we're expecting approval by July 6th. Could happen really any day, but will happen by July 6th, and everybody's expecting it to be approved. So that's kind of where we are. Three drugs, but really one that we're going to talk about because we're expecting full approval here any day. So I don't want to take one quick step back before I get into the drug and who we can use it on. And the step back is answering that question that I get every single day, which is, what's the difference between dementia and Alzheimer's disease? And I just want to remind everybody, what is dementia? Dementia is this: decline in cognition that interferes with daily function. We think about cognition in different sort of buckets, different things that the brain does: memory, organizing and planning, language, orientation. We look for changes in memory and thinking that really are getting in the way of somebody doing the things that they've usually done. Over the years, they've done them well. Now they're having problems. That's dementia. That's all it means. It can be really mild. It can be really severe. There are lots of causes of dementia, and one of them is Alzheimer's, and it's the most common one, but there's many others. And so it's an umbrella term that simply means change in memory and thinking that interferes with daily function, regardless of cause. So what is Alzheimer's disease? Well, it's the number one cause of dementia. And there's a little more specificity to it. And so to think about dementia versus Alzheimer's, they both represent this syndrome where we're sitting down with the patient in clinic and we see there are memory and thinking problems that are really crossing a line, which we draw sort of in the sand as, does it interfere with daily function? If it does, we call it dementia. Alzheimer's has the same syndrome. The causes of dementia are many. The causes of Alzheimer's are, and I put that in quotes for a reason, but amyloid plaques and tangles. These are the things we see in the brain with what we call Alzheimer's disease. I put cause in parentheses because we don't really know what's driving what. We don't know cause and effect here, as I'll talk about. But the thought has been, over the decades that these amyloid plaques and tangles that we see in the brain are what represent Alzheimer's disease. And so the difference here is we look for that syndrome, and when we think amyloid plaques and tangles are present, we call it Alzheimer's disease. So what are amyloid plaques and tangles? Here they are on a microscopic picture. So we're zoomed way in on a small sort of cross section of the brain, or little sample of the brain of somebody who had dementia. And what we see are lots of amyloid plaques. These big splotches are made up of a microscopic protein called amyloid. And then these little tangles here, these are brain cells filled with what we call neurofibrillary tangles. So the amyloid plaques are really what this drug goes after. But this is really the definition, conventional definition of what Alzheimer's disease is. Somebody who had the dementia syndrome in life and then has plaques and tangles in their brain. And here, actually, up until about 10, 12 years ago, we could only see these plaques and tangles when somebody died. And we looked under the microscope. Actually, it's about 20 years. I'm getting old fast, but about 20 years ago, the very first techniques came out that allowed us to detect in life these plaques and tangles in the brain with PET scans. So we now have the ability to detect amyloid plaques and tangles with PET scans, with lumbar puncture, and with blood. So we don't have to wait until somebody dies, look under the microscope. We now can see these things in life. And blood is on the research side, but it's coming very soon into the clinic. We think probably a year or two, we'll be using these blood tests in an FDA-approved way. We're using them on the research side a lot. But these things can tell us whether or not somebody has a high probability of having plaques and tangles in their brain or a low probability of having them. So this is what Alzheimer's disease is. I thought it was important to kind of look at what is amyloid. It's here building up in the brain. This is microscopic, but these large splotches are the amyloid building up in the brain. And this is what the drugs go after. And then one more, just I'll just kind of explain how the PET scans work. These PET scans might be something we begin to use in practice if Medicare starts paying for them. Right now, they're really expensive and nobody will pay for them, so we don't use them much. We use them a lot on the research side, but what we're able to do now is inject a tracer, basically a little medicine that actually is designed to stick to amyloid in the brain. We can inject that into the bloodstream very safely, and it's designed to stick to amyloid, and it has a little radioactive tip that gives off a signal. So if it is sticking to amyloid and being retained in the brain, then our PET scanner can see it. And our PET scanner, then we can take a picture and we can see if somebody has elevated amyloid in the brain or low levels of amyloid, or no, actually the one on the left is really no amyloid, even though there's some color there. But so we can see this now. So I'm going to show some pictures like this in a minute, but these are major advances just in the last 20 years, our ability to see amyloid and tangles, but see these things in life, and then now have a drug that can go after it. And so we've been testing for probably 30 years this idea based on, maybe amyloid is driving the disease. Can we understand how amyloid is made and block it? And now, can we actually use medicines like the ones I'm going to talk about to remove it from the brain? And that's what we're doing now with these new drugs. We can actually sort of trick the immune system, our own immune system, into pulling amyloid out of the brain. The big question remains, and we will continue to argue about this, but how much is amyloid involved in the disease? Is it the fire? Is it the smoke? Does it cause the disease, or is it the byproduct of the disease? And that remains really, we're still sort of arguing about that. But what we do know now is that removing amyloid from the brain does, for some people, slow the disease down a bit, which I'll show you here in a second. But first, how do these drugs work? So monoclonal antibodies, what does that mean? First of all, mono means one, clonal means type, more or less. So monoclonal, one type of an antibody. What's an antibody? It's an antibody is sort of your immune system's approach to targeting an enemy of some sort. So the figure on the right is taken from something I found on the internet that was showing how these antibodies, the Ys that are floating around, are sticking to COVID in this case, because monoclonal antibodies are something that have been used to fight COVID. So an antibody designed to stick to COVID, and then your immune system sees it and then targets it and gets rid of it. So, so the same idea here is we are now able to generate these antibodies that are designed to stick to amyloid, and then the immune system sees that as a problem and takes it out of the brain. And monoclonal antibodies are something that are being used pretty widely now for cancer, autoimmune disorders, and then, as I mentioned, COVID, and now Alzheimer's disease. So that's what a monoclonal antibody is. So Leqembi is the one that we expect full approval here in the next few weeks. Received accelerated approval in January 2023, just a few months ago. And it's a drug that's given as an infusion. So it's given in the vein every 2 weeks. So we'll come back to this. That's a bit of a burden, but every 2 weeks for an hour. So people will have to go to an infusion center to get these drugs. And eventually we may see home infusion being the way to deliver this. So who do we treat? The drugs have been tested on, and the evidence is coming from patients who have really, really, really mild impairment or mild cognitive impairment, or are in the little bit more moderate stages of that mild impairment and are being diagnosed with mild Alzheimer's disease or mild Alzheimer's dementia, who have evidence of brain amyloid. So that's sort of the key. People with mild impairment in the MCI stage or the mild Alzheimer's stage who have evidence of brain amyloid in their brain, either by lumbar puncture, so spinal fluid assessment, or amyloid PET that I've shown you. That's who we're going to be looking for. So mild cases, not the moderate or severe stages. In fact, our experience with that is that those patients don't respond, and it's just not worth it. And the drugs have not really been thoroughly studied on that population. So, and then the other thing to think about is not everybody will in these early stages will have access or be appropriate for the treatment. We're going to need to do safety assessments up front, do a brain MRI to make sure we don't see changes of little microhemorrhages, we call them, in the brain. We need to do a gene test for ApoE4 to understand somebody's safety risk, because if you carry the E4 gene, you're at a little bit higher risk of the problems we can see with these drugs. And then people who are on anticoagulants, we're going to really avoid treating for a good while until there's more evidence around safety. So we're probably looking at maybe 20% of the population that we see in the clinic who are going to be, have access or be appropriate for considering treatment. There's sort of a checklist of things that we're going to have to do to make sure somebody's appropriate. We got to get the history and make sure things look like Alzheimer's, do the cognitive testing, get the MRI I mentioned, do a lumbar puncture to look for these biomarkers, do the gene study, and then do a checklist of things to make sure safety is, a person's appropriate for this drug. And so we're working through how we're going to get all that done on patients who we're evaluating for this drug. And what do we expect from treatment? Well, it's clear it's not a cure. So, the drugs don't cure people. They don't reverse things. They're designed to have an impact on amyloid. It's clear these drugs have an impact on amyloid levels in the brain, and I'll show you some pictures of that in a second. But what's not as clear is how much that translates into true measurable benefits in patients. But it does appear on average to show a clear slowing of decline on average for patients who are treated with this. But it's also clear that in that group of patients who are treated, not everybody responds. Some do and some don't. We don't exactly know which patients are ideal and which ones aren't in this group. And those are things we're going to learn over time. So not a cure, and it slows things down. And it does have a big impact on amyloid levels. So this is a figure on the left. The lines represent amyloid levels and people treated over time. And the lines are dropping. The blue and the green lines are dropping from treatment. And the red line is people who are treated with placebo. We don't see a decline in amyloid. We do on treatment. And the figure on the right here shows somebody who's treated with placebo. You don't see any change in the colors. This person was treated with drug and saw a dramatic reduction. The reds are gone. The amyloid and in the cortex of the brain is gone, or down to normal levels, I should say. And that's pretty dramatic for us to see that level of amyloid reduction. So these drugs work. They do clear amyloid from the brain. The big question, and here's data from the drug that we expect to be approved, Leqembi or lecanemab, the long name for it. It does lower amyloid quite strongly. So over 18 months is what we're looking at here. But how much decline or how much change in decline do we see in these patients? This is the figure that really the FDA used to or is using right now, we assume, to likely approve the drug. It shows two lines. It shows two lines, and going down is worse here on these lines. So the placebo patients decline in the blue line, and the patients treated with lecanemab decline less so. Sorry, my phone may keep ringing, but we see a separation of lines. That's the key message here, is we see a separation of lines, indicating that patients who are treated on average are doing better than patients on placebo. What we're going to argue about probably for the next few years is how big is that separation, and how much can we? I'm going to do that. Sorry about that. So how big is this separation, and is it worth it? What's the benefit here? And what we're probably seeing, what we're probably seeing is about a 3 to 6 month separation over 18 months. So the key information here is people are not plateauing. We're not seeing, we're not stopping the disease. Patients continue to get worse, but they get worse less rapidly than those who are treated with the placebo. The other important thing is this is 18 months. And so this separation of the lines is occurring slowly over time. And we're seeing that separation possibly increase over time. And what we don't know, and what we're really interested in, is what happens 2 years out, what happens 5 years out. Do we continue to see a separation, or do these lines stay parallel? Lots we're going to learn over time, but we're seeing over 18 months, we're probably seeing sort of a delay in this measure of about 3 to 6 months. So now one other thing is, if you've ever participated in a research study, you know that there's a lot of measures that we do. And the nice thing about this data that came out was the other important measures that were done that assessed cognition and assessed functional decline, they also separated, and they separated in a significant way. But they also showed that patients didn't get cured, and we didn't stop things. So this is the data. This is what we have. This is what the FDA has, and now it's about, all right, how big of an impact is this? We're going to argue about costs versus risks and benefits. How much can we expect from the drug? And this is where we make the decisions to treat or not to treat, is weighing the benefits and weighing the risks. And so this is going to be kind of a tough decision for patients and for doctors, but it's going to be a joint decision that's made, really talking about what can we expect from the drug, and then what are the risks and what are the costs, and balance those things, and then make a decision, is it right for that patient? So let's talk a little bit about what are the downsides. So burden. One is we know given the drug is going to take an hour every 2 weeks, and we're going to treat people for at least probably 18 months. Costs. We don't, so the drug has been priced at at wholesale at I think $26,000 a year. And so that's wholesale cost. And what we're working on now is who's going to pay for this. Our insurance company is going to pay for it, and will Medicare pay for it? And the answer is yes, Medicare will pay for it, but there's some strings attached. But costs have to be factored in. Safety and the safety monitoring that we have to do when we treat patients. We're going to repeat MRIs 4 times in the very first year that we treat somebody with this. And the reason why is we know about 30%, about 1 out of 3 people we treat have changes in the brain of brain swelling, which we see as shifts in sort of fluid in the brain, and then little microhemorrhages, which put people at risk for larger hemorrhages. So we see that in about 1 out of 3 people. Now, most of those people have no symptoms. They don't know it. We only know it because we did an MRI scan. When patients have symptoms, and 75% don't, 25% do. And when they have symptoms, it's usually headaches, maybe a little confusion or dizziness. So it's usually manageable, but about 1 out of 100 people actually have pretty significant symptoms and may need hospitalization. And there have been a few reported deaths. So there can be serious side effects, although they're uncommon. So we got to weigh these things. So these are the downsides versus the benefits that I've shown you, where some patients may slow down quite a bit, some don't. And on average, we see sort of a delay in these measures that we want to see slow down. So weighing those risks and benefits is going to be really important. And it's going to be a really individual decision that's made sort of with a physician, speaking with the patient and the family, and coming to a decision about whether to treat or not. So the other big question is who's going to pay. Just a week ago, Medicare, CMS, Centers for Medicare and Medicaid Services, CMS, announced a plan to say, yes, they will pay for it. Although it's not quite so simple. They will pay for the drug for patients on Medicare if the drugs do get full approval, which we expect for Leqembi, and if patients are enrolled in a research registry. What does that mean? Well, it means, you got to do it at a site that's participating in a research registry and taking some of the data that's collected during the clinic visits, and putting them into the research registry so that we can assess over time whether these drugs are having the impact that we expect them to have. So Medicare wants to collect data and assess that data to prove that these drugs are valuable and are having the impact that we expect. And I think this is a reasonable thing for Medicare to do. There's going to be a lot of sort of criticism around it because it does make it a little bit harder for patients in, say, rural areas or patients in underrepresented areas to have access to physicians who are going to participate in these types of registries. So it's going to make it a little harder for people to get the drug. But I think it's reasonable because there's still a lot of questions in terms of how big is the impact of these drugs and how big is their value to patients. And so it's going to give us a way to collect that data. So there's a ton of challenges with these drugs, and the challenges tend to revolve around access to the drugs and the barriers that there are to getting treatment. There's not enough specialists. There's not enough dementia doctors or Alzheimer's doctors. And if you've tried to get into our clinic, you know it, because it can take 6 months to a year to get into our clinic right now before these drugs. And these drugs are likely for the short to midterm going to only be prescribed in specialty clinics like ours for the most part. So because it's hard to identify the right treatment candidates, and it's complex in terms of prescribing these drugs and monitoring the drug effects over time. And so that's going to create issues, and participation in the research registry going to create issues in terms of access and sort of accentuate or exacerbate those access issues that we see just with regular drugs. And so it's going to take some time to do it right. The figure on the right, or the picture on the right, comes from a Wall Street Journal article just from a month ago, and which quotes me and a bunch of other people like me around the country saying these drugs are going to be very hard and challenging to deliver. We're going to do it. We're going to figure it out, but it's going to take time. But what we don't want is for the only patients who are getting it are the ones who, live near the right center or know the right people and find a way in. We need to figure out how to give these drugs to everybody who needs it, give these drugs to the appropriate patients and to all the patients who deserve it and want it. So that's going to take time and effort. And so, but we're going to work that out over time. So I'll end on this. I'll say, we're on the verge of new therapies. They're actually here, some new therapies. We're going to need more. We're going to, the future will bring, I think, multiple approaches that we use in folks to go after this disease. And I think when we talk about a cure, it's not a question of if, it's a question of when. And this is one step in that direction, these new drugs. So it's an exciting time. It brings a lot of new challenges, but it's exciting. And we're going to take on those challenges as they come. So, okay. So sorry about it's 2:30. So we'll take some time for questions. Sorry, my phone kept ringing. I know that was probably very distracting. It was to me, so sorry. But all right, appreciate it. The great attendance, and we'll do more of these too as these evolve. This is going to evolve fast, and I think we're going to have opportunities and new information as the field evolves. So we'll try to bring that to you as things evolve. So thank you, and let's see. We'll take some time for questions, even though we're a little over time. So I'll check the chat, and I don't know, Tina, if you're monitoring the chat.
Yeah, you've got quite a few questions in there already, Jeff. It looks like it starts with Beth wanting to know about amyloid PET scan and if that's a way to confirm, and then asking some other questions in that.
Okay, so amyloid PET is one way to confirm the presence of amyloid. The other is a lumbar puncture, spinal tap. And that's probably the best way right now to detect the presence in terms of cost effectiveness. And it also gives us a little information on tangles that can be helpful, or maybe give us a little more information that might help us. But so a lumbar puncture or an amyloid PET. So right now we generally only do lumbar punctures because amyloid PETs cost a lot of money. And Medicare doesn't pay for them yet. So, and then is Leqembi used with amyloid only? And the answer is yes. If amyloid is present and we see somebody meets criteria for mild cognitive impairment or also mild Alzheimer's disease, they meet those criteria and have amyloid present, then we could think about using Leqembi. Okay, so how long do you have to continue the infusion treatments? This is a good question, and the answer is not really known yet. Practice will evolve. Right now, the studies have treated for 18 months with Aduhelm and with Leqembi. And so we'll probably follow that, treat for 18 months and kind of try to take another picture of the brain or do another lumbar puncture to see, have we, had an impact on amyloid? If we have, we'll probably take a break and try to monitor over time, does amyloid come back? We think it may come back gradually over years. And so we might be able to take a break and monitor and then retreat in the future. The third drug that doesn't have approval yet, donanemab, is one where it was designed to actually try to reduce amyloid quickly and assess over time. And when a reduction occurs, stop treatment at 6 months, 12 months, 18 months. And so that's how practice will evolve over time in terms of how we're using these drugs, but it's probably going to be focused on monitoring amyloid levels. If we get them down, then we'll pause treatment for periods of time. What can we see for decline on an MRI? So an MRI shows us the shape and size of the brain and any injury that might be happening. It does not show us amyloid. So an MRI scan just shows us shrinkage of the brain, or changes sort of in the structure of the brain. And so with these drugs, actually, we were hoping to see slowing of shrinkage of the brain using these drugs, and that has not played out that way. Turns out that removing amyloid from the brain might actually increase the shrinkage of the brain, and we don't understand that. So we're seeing maybe some increase in the shrinkage of the brain from removing amyloid, so the volume of the brain might be reduced from that. At the same time as we're seeing slowing of decline. So we're scratching our heads on that, and that's something that we're on the research side really interested in and keeping an eye on. But MRIs are not, so it's more, so in the realm of science right now, we don't use the MRIs to look at changes in the brain, to assess treatment effect. We use the MRIs to assess for the possibility of the adverse effects of the drug on the brain. So, and when you speak of your clinic, does that include all patients seen at your research center? Actually, we have research. We kind of have two avenues in the ADRC. One is the research side, and the other is the clinic, the practice side, where we're diagnosing and prescribing. And the research center folks would not. We would have to move. If you're somebody who's purely seen on the research side, we'd have to move you to the clinic side as well to access these drugs. So if you're participating in research and you're interested in these drugs, you hopefully have a little bit more information than most, but through your participation in the program as to whether you might be eligible for the drugs. But if you are, so ask the coordinator, ask the docs involved, and try to get some information there. And if you're really interested, then ask if you can get pushed over sort of into the clinic side, or if you need to be. How do we get a recording for later viewing by my husband? So we're going to post this on YouTube, right, Tina?
Yes, that's correct. It'll be
Great.
available on YouTube.
We might have to reshoot it with the phone not ringing. So we'll do it again. And when do you think we'll know the cause? Well, the cause, instead of focusing on the cure. So the cause ultimately is how we find a cure. We know a lot of things change in Alzheimer's disease, and one of them is amyloid. Another is tangles build up, but there's a lot of other things that we see as well. And so they all sort of work together and against us to create Alzheimer's disease. We're trying to understand what triggers all that, and if there is a single trigger. And when do we think we'll know? I don't know. We're going after all those different things that change in the brain and trying to understand if we go after them, does it impact the disease? And I think we're going to have to go after 2 or 3 or 4 of them to really, really, halt this disease. So can't project that, but we'll be debating it for a long time until we figure it out. And will participants in the research get to know what their test results are? Yes, we have created ways. It depends on the research study, but we're working really hard to create ways for you to get that information back if it's appropriate. And usually it is now. It wasn't 10 years ago. Now it is. So we could talk for an hour about that. But so, yeah, ask, because we're really trying to find ways to get the information back to you. And then, is there any value today in doing a spinal tap to check for the presence of amyloid if there is not evidence of MCI? Great question. The answer is probably not right now. And that is a long answer, but there's a much longer answer, but we haven't proven that for individuals who don't have evidence of memory change, but do have evidence of amyloid. Turns out that's about 30% of people over the age of 65 have amyloid in their brain, but no memory problems. We're testing the idea, if we go after those folks and remove amyloid, does it reduce their long-term risk of Alzheimer's? And we don't know the answer yet. And if we prove that, we're using the drug Leqembi actually in a big national trial, trying to understand if we can prevent Alzheimer's in those people. The answer is not yet known. In fact, we've spent the last 8 years doing another study where we used one of the first generation drugs going after amyloid, and we did not see it have an impact on risk of Alzheimer's disease for the individuals who have evidence of amyloid in the brain. So long answer to your question, but the answer is probably not yet. And if you're somebody in that category who really wants to check, or really wants to, participate in our research and really help us understand, and get to that, answer that question. But if you are in that category where you think you have a high risk, I think prevention studies are an option, and keeping your eye on how things evolve here, because, that's ultimately what do we want to do? We want to spot the disease before it starts, before the symptoms start, and intervene to prevent it from happening in the first place. So, And why does ApoE4 create issues? Yeah, this obviously I'm kind of rushing through. There's tons of information layered in here, and this is a great question. ApoE4, individuals who have an ApoE4 gene are a little bit higher, or actually are at a higher risk of developing those side effects of swelling in the brain swelling, or the microhemorrhages, and probably double the risk. And so we want to know that before we treat somebody. Are they at that higher risk, or are they at the lower risk? So that's what we're looking for, and that's why we're measuring the ApoE4. How much improvement do we see in the activities of daily living? Those figures on the right that I showed, where I showed all the data points, show a slowing of decline in activities of daily living. So we still see decline in activities of daily living in people who are treated with this drug, but it does appear to slow on average for people who are treated, which is nice to see that kind of data sort of converge on, yes, these drugs are having an impact, an important impact for people. And I keep saying on average, because you got to imagine, us treating in these trials 500 people, 1,000 people with the drug, and comparing them to what did we see in the 500 to 1,000 people not treated? And on average, we see a slowing. What does that mean? It means some patients actually probably do a lot better than they would if they weren't treated. And it means some people who are treated aren't doing better, and they're declining. So on average, people decline, but they decline at a less rapid rate if they're on the drugs. And so we do see slowing of decline in activities of daily living, slowing of decline on things like the MMSE, slowing of decline on our bigger measures like the CDR, sum of boxes. And so so lots of different measures, and we see slowing of decline. If you had a lumbar puncture, but the results are unclear, can you use one of these drugs? I think we wouldn't really want to use one of these drugs unless we were pretty confident somebody has amyloid in the brain. It's probably not worth putting you at risk if we don't know you have amyloid in your brain. So if it's an uncertain result, it might be, you might be somebody we'd want to do an amyloid PET scan on to confirm, or repeat the lumbar puncture. So, and I'll tell you, I'll look at, we've got a lot more comments and questions. And let's see, I think that's it. So thank you guys. Thanks everybody for being here, and stay tuned and spread the word on what we're doing. We are going to have access issues. We have them now, we're going to have them, but we're working really hard on trying to solve those problems. We have to double, triple in size. That's going to take years. We have training programs that we've created for this day, including a new nurse practitioner, physician assistant fellowship that's starting July 1st. We have a doctor training program as well. And we got a fellow coming in next year, and we're really trying to train people and grow the workforce. And we're trying to grow ourselves, and we're coming up with new innovative ways to try to get more people through the clinic. And so we're working really hard. It's going to be frustrating, I bet, for a while, for probably a few years, all over the country, really, to sort of get the capacity we need to make sure that the right patients and all of the right patients have access to these drugs. So, all right. And we need your help. We need you to spread the word, and that we need more of what we're doing. So we appreciate you being here, and stay tuned.
Thank you so much, Dr. Burns, for your presentation. It's always such a delight to have you joining us on our weekly webinar. Next week on Thursday, 2 o'clock, same time, same place, we have Dr. Lauren Tomey presenting to us about Down syndrome and brain health. So looking forward to hearing from her. The recording will be available on YouTube shortly. You can access that by navigating on our website under weekly webinar, or using the link in the reminder email. If you have any questions or comments in the meantime, please email us at myalliance@kumc.edu. Thank you again, Dr. Burns, and thank you so much, everyone, for joining us. Have a great rest of your week.
Thank you.